Hello, everyone. If you're still grabbing food, feel free to do so. I just figured we should start now in order to secure some time at the end for a robust Q&A session. So also on a side note, if you do have questions, you can raise your hand, but try hold them until the end so we can have more of a Q&A discussion at the end. So today we have a very popular speaker, Dr. Aasim Padela. Dr. Padela is the director of the Initiative on Islam and Medicine, assistant professor of medicine in the section of emergency medicine, and a faculty member at the McLean Center for Clinical Medical Ethics. He holds an MD from Weill Cornell Medical College, completed his residency in emergency medicine at the University of Rochester, and received a master's in healthcare research from the University of Michigan. His Islamic studies experience comes via a Bachelor's of Science in Classical Arabic from the University of Rochester, seminary studies during his formative years, and continued tutorials with Islamic authorities throughout his career. Dr. Padela is a clinician, researcher, and a bioethicist whose scholarship lies at the intersection of community health and religion. He utilizes diverse methodologies from health services research, religious studies, and comparative ethics to examine the encounter of Islam with contemporary biomedicine through the lives of Muslim patients and clinicians, and in the scholarly writings of Islamic authorities. Through systematic research and strategic interventions, he seeks to improve American Muslim health outcomes and healthcare experiences, and to construct a multidisciplinary field of Islamic bioethics. As a Robert Woods Johnson Foundation clinical scholar from 2008 to 2011, he developed a community-based research methodology to study and intervene upon American Muslim health disparities. Then in 2011, as a visiting fellow at the Oxford Center of Islamic Studies, he studied Islamic moral and theological frameworks. And from 2013 to 2015, as a Templeton Foundation scholar, he led a national survey of Muslim physicians, bioethical attitudes, and professional experiences. His current areas of research in cancer screening, end-of-life care, neuroscience, and theology are all funded by the Templeton Foundation and the American Cancer Society. Without further ado, please welcome Dr. Aasim Padela.
Thank you. It's a pleasure to be here. Thank you, Norman. Thank you, Peggy. Thank you, Dr. Brown, and the Office of Health Equity and Inclusion for bringing me back here to the University of Michigan to share with you some thoughts basically on the patient side of things. I know that we are going to have several questions, so as Norman said, I'm going to kind of speed through some of the lecture, be a little bit provocative, so we can have a robust discussion at the end. So to begin with, Norman mentioned that I lead I lead the Initiative on Islam and Medicine at the University of Chicago, and we see ourselves residing at this junction between the healthcare system and the Muslim community. So we want to be individuals and a research program that looks at the religious influences of Muslim health behaviors as they're lived out in the Muslim community, and that can lead to healthcare challenges and disparities. And then kind of cycle that back to the healthcare system so that it can accommodate those patient values and systems and needs. At the same time, we reside between the seminary and the academy along the axis of Islam, where we look at Islam as a lived tradition embodied by seminarians, who then all are authors of the tradition as well, how they think about Islam, and then how the academy, Islamic Studies Academy, thinks about Islam as a lived tradition, but one that is practiced within the communities. Our project is one of translation between all of these stakeholders so that hopefully we can lead to a more holistic understanding of the intersection between the Islamic tradition and biomedicine in large. So with that said, today I'm going to just speak about the healthcare system and the Muslim patient experience access here. Particularly, we're going to talk about the concept of healthcare accommodations. Then I'm going to give you some data from a series of studies that we did on Muslim communities here in Michigan and in Chicago that talk about what healthcare accommodations mean to them and what it would look like for the healthcare system. We're then going to put on the ethics hat that I wear and talk about the ethics of accommodating religious worldviews in healthcare, largely for a second in light of the four-principle framework, which many medical students learn or are indoctrinated in medical school, and then kind of practically at the ground level from the vantage point of healthcare system decision makers when they have to adjudicate between different preferences and priorities. Then I'm going to leave you, hopefully, at the end, with some greater understanding about Muslim patient healthcare needs, but really I hope you leave here challenged and challenged but motivated to bring about a patient-centered, equitable, and holistic healthcare system here at University of Michigan, and then when you graduate, wherever you go. So I'm an emergency medicine doctor, right? This is where I spend some of my time in the ED with a lot of different power differentials and patients often leaving bewildered of what happened. So I'm going to start with a case, as we do often, from the ED. So here's a patient. This is a 35-year-old female who presents with a headache. This is the triage note that she was jet skiing in Lake Michigan. There was an accident. There was no nausea or vomiting that she reports, questionable LOC. And she has no weakness but a moderate headache. Those are the vital signs. And then she comments to the nurse at the intake, so she walked in, she was ambulatory, that she would like to see a female clinician. So assuming that you're in a single pod ED, all right, what would you do? Would you try to find a colleague who's a female to see this patient? So what I'm going to do in this beginning part of the talk is have you raise hands on various questions. And then in the end, we're going to talk about what that means. So here's a question. You're a physician in a single pod ED. Would you try to find a female colleague to see this patient? Yes or no? Those say yes, raise your hand. Okay, those say no. The rest of you are unsure. Okay. All right. So if the patient wasn't that patient, but it was this patient, and she wanted to see a female physician, would you try to go find one? Raise your hand, yes. You guys don't like Hillary. Okay. All right. Well, I thought I was in a blue state. Anyway, who would say no? A couple of people, and the rest of you unsure. What if this gentleman came in and said, I want to see a male physician? Would you go try to find one? Raise your hand and say yes. And no? All right. We'll just stick with yes, because people don't want to say no. What about if this individual said they want you to see a male doctor? Who would say yes? Raise your hand. Okay. Who would say no? All right. So I'm going to flip this and I'll tell you what I saw here. I saw here, when we were raising our hands, that actually people would accommodate this individual more than Hillary, right? And this was the least accommodated, okay? And no one said, there's a couple people up front who said no to many different requests, but no one said no, okay? So now I'm going to change it. So what if this person said, I want to be seen by the chief of emergency medicine? Who would say, yes, I'll find the chief, or the department chair, or whoever else it is? Yes? Okay. And what if this individual said, I want to be seen by a full professor, none of these residents and medical students? Raise your hand. A few. And this individual said, I want to see by a white doctor. Raise your hand. Okay. So a very patient-centered healthcare system. You know, there are differences in the way that we think about different types of accommodations or requests, right? That's just clear and apparent. So just so you weren't here privileged to see, there were some people who would say yes, right? Here, less here, and almost only a couple people here, okay? So the question really for us is then, at one level is, can patients ask for a specific provider type that should we accommodate that request, right? But the real question, I think, are what are the considerations that influence our decisions? Because clearly we make different decisions on different types of requests. Based on what? So I'm going to now ask you guys to kind of give me some ideas of the second question. What considerations influence your decision about just the scenario I put out here of accommodating that request? Religious beliefs? In what way? Like if the value was a religious one, what would that do? I'm sorry? It goes up, so you're higher priority? Okay. Other thoughts? Explain what that means. So I think you're saying you want to try to right the social wrong. Is that what you're saying? So you want to be helping the less empowered become more empowered. And those who are already in power, do you feel less inclined? Okay, other thoughts? Please. You have a lot of implicit assumptions and biases into your decision making, right? You're not going to be able to necessarily know what that's coming from. So, but I think your points are all valid. Last comment, and then I'm going to kind of move on. Is there anybody else want to share some other reason or other consideration? Go ahead. Acuity, but largely this is where the debate lies. The patient values that lead to a preference request that you assume exist or don't exist, or they tell you they exist, and the provider values regarding the request. So you can imagine a scenario where someone who is the only female in a medical class, the only person who got into neurosurgery, right, and now is being told, ask, I want to see a male doctor. How would that go, right? So there are also other things that happen internally to us as providers where we make value judgments about what the patient is saying or not saying. So we're going to talk about that. One of the things I said I want to introduce this term of healthcare accommodations. These are two different ways that people define it. Cultural adaptations that would make patients more comfortable in the healthcare setting, simple definition, or modifications in healthcare delivery based on patient values. So the idea of patient embeddedness is sort of part of the definition. And I would think this is from those who are in this field who know this is a model of reducing healthcare disparities and improving cultural competence to reduce healthcare disparities. But here, accommodations lies at the intersection of all of these, right? So at one level, you're trying to think about, as my colleague here said, the underserved in society. How can you right the wrongs? How can you be more socially just towards them? So part of that would involve making accommodations the way that you deliver healthcare. If you want to target a cultural population, they have certain types of beliefs and values. Right, we have a Japanese family health program here. Right, there's different ways that the clinic runs because of their value system, and so that is cultural targeting to a patient population. Maybe they're not underserved. Right, in that case, you have this idea of patient-centeredness that we all talked about. We want to have an idea of what can we do to improve the patient outcomes. What's the best way of delivering healthcare? Then again, leads to some sense of accommodations. And then lastly, this big thing, that amorphous term that has been defined in many different ways and to different people that means different things. But this idea of cultural competence, right, also leads to accommodations. Because yes, you have knowledge, but then it needs to be applied in some sort of way. So it resides at this intersection of all these different streams and thoughts and ideas that are pervading medical care delivery today. But the question always is, what values do we accommodate? Right? To what extent and how? Right? And how? So the rationing of cultural accommodations is a hot topic that many people don't talk about. But as bioethicists, and I am of that clan, I guess, and that guild, we need to think about. So I'm going to switch gears and talk a little bit about what you all brought me here to talk about, Muslim patient care and Muslim patient needs. So we're going to switch gears, but then return back to this question about the ethics of cultural accommodations. So Muslims are diverse, right? The estimates are there are 5 to 7 million Muslims in the United States presently. They're ethnically and racially diverse. So these are some statistics from various different groups. That about a quarter of them are African American, a quarter South Asian American, and a quarter Arab. They have a diverse immigration history. Most, right, so the dominant component of the American Muslim population presently is immigrant population, foreign-born, but a sizable minority here are native. And then you see that all of these three components, these ethnic and racial components, have a different history. Right? So African Americans, there are some scholars, some actually from University of Michigan, who would note that nearly 20% of the individuals who were brought here in the slave trade came from Muslim countries of origin. There are actually these amazing stories of individuals who then would try to keep up their prayer and recitation of the Quran in various hidden means. But that was discarded, that was lost, that tradition was lost. You have Arab and South Asian immigrants who came here in the 19th and 20th century. Here we have the Ford brought a lot of Arabs from Lebanon and Syria in Michigan, right, in the early 1800s or so. Then you have African immigrants. More recently, we know that from like Somalia, or at least in my lifetime, Somalia and other places that came here as migrants. They have different histories, different socioeconomic backgrounds, but what ties them together is this notion of an Islamic identity. So we should know there's some myths about American Muslims, largely because of the media and how we think about it. But Muslim Americans are English literate. Nearly 87% are English literate. So when we think about healthcare accommodations, a lot of times people think about cultural and linguistic competency. The linguistic is emphasized. But here, for this population, there isn't a problem about speaking English, largely. For the newer refugees, potentially, but most of the people who came here as skilled laborers have college degrees. They don't need you to help them understand big terms. As far as household income, you'll note here that Muslim Americans on the lower spectrum, right? So there are a lot of refugee populations that have come recently that are on the lower spectrum, higher than the general population of the United States. But in terms of those who are socially mobile in the upper spectrum, nearly the same amount of people have household incomes over 100,000 as the regular American population. This population is very religious, right? So they're highly religious. You see this breakdown between Sunni and Shia. 65% Sunni, 11% Shia. 69% say that religion is a very important part of their life, compared to 58% of Americans' general population. 65% report praying daily. And then this is a really high number. 50% attend mosque at least once per week, compared to 36% of the regular population. So, I say American Muslims, I'm talking about the Muslim aspect of identity. You should note, yes, that there is diversity, yet compared to the general demographic here, they are more highly religious than other populations. So then when we get to the healthcare literature, the question becomes, what do we know? Right? It's about American Muslim health disparities. You see here Afra, who was a medical student now. She was an undergrad when I was here. We did this study a long time ago trying to understand what's known about Muslim Americans and healthcare disparities. And you see this is what we found from our systematic literature review, that in this period, from 1970 to 2009, there were only, if you did the search term in PubMed, you found 2 articles. And then if you added some other disparities terms, you found 10 articles. So that's the landscape. We know nothing, right? We knew nothing. And my career has been trying to bring some light to these issues. So I'll present some things here. The larger challenges in studying American Muslim health disparities, because a lot of people come at cultural competence and healthcare, from a healthcare disparity lens, from a social justice lens. Well, you'll know very little about this population then, because we can't get national samples of American Muslims. Religious affiliation is not captured in national databases, not in the surveys that are done by ISR here or NORC at University of Chicago. Naming algorithms are unreliable. We've done some of this work. We're 9% capture rate or 25% capture rate. That means you can't do large survey sampling. It would cost millions of dollars. There's a mistrust of state actors. And what I mean by that is when you try to do community-based sampling, there was a big study done here, Detroit Arab area survey, but you found this was palpable in the community. And when you try to do community-based, zip code-based prospective research, there's a distrust, and some people just opt out, so you get biased samples there. As far as assessing the Islamic component, right, so most of the measures of religiosity are based on Christian worldviews. They don't exactly fit well with Muslim worldviews, so these measures don't exist. This is a challenge, again, for myself and others who do this research. We have to create our own tools and then validate them. So the line of the career span of doing one study becomes many, 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 many years. And largely here, just about religion, we don't know what we don't know. Right? It's a thing that pervades our lives. It's every day in the media. But when we think about in the healthcare system, it's something that we don't know what we don't know about religion and how that affects people's health cares. Oftentimes, people don't take a good spiritual history. And then when we have these challenges about religion. Sometimes religion is put forth as a challenge, but nothing is actually then thought about what that means to the individual. Yet, I will say there are clear ways in which religion can influence healthcare disparities amongst American Muslims. This is a paper Farr and I wrote a couple of years ago. I'm just going to give you this overarching view as a model of how we think about the religion influencing potential healthcare disparities. So one level is through beliefs, right? So Islamic beliefs influence how you think about health, illness, and disease. So these are studies below. So there was a study about pregnancy. If you view pregnancy as a blessing, then that influences your attitudes towards contraception. And that could lead to different health differences, right? Healthcare differences, delivery differences, quality of care differences. Or this idea that cancer is based on cause decree, right? Then that influences attitudes and intentions towards preventive cancer screening. And that can influence healthcare disparities. On another sort of larger box, Islamic values and ethics. So the idea that Islam prescribes alcohol consumption can lead to decreased health risk exposure from alcohol consumption, right? Disease types and also injuries. This is well known in Mormons. There have been studies done in Mormons about alcohol and tobacco use, that they have different health differences in that population because of these religious proscriptions. Similar things could be said about Muslims. This idea of gender concordance, which I started out with, influences many healthcare seeking patterns. I mean, I'll show you some data. It's pretty striking. And then the idea, particularly where we live today in the United States, Muslim identity exposes you to is a health risk exposure, I would argue, right, through discrimination, both societally and in the healthcare system, and that leads to delayed healthcare seeking behaviors as well. Again, some data I'll share with you in a few moments. So let's get to deconstruct that first sort of question by that hypothetical Muslim female at the ED. She wants a same-sex provider. So what is the empirical data behind that? So I did a study here of 97 adult Muslims attending mosques because we wanted to get more religiously affiliated Muslims. We found that, this is men and women, that 21% had delayed seeking health care due to lack of a same-sex provider. They self-reported this idea. In Chicago, I am focusing on Muslim women's health. So we did a larger sample from mosques and community sites. So this is not just going to where the Muslims congregate in terms of worship, but rather going to sites like a women's resource center or a social service agency where Muslims interact in their daily living. Maybe they're not as religious, but we found 53% had delayed healthcare seeking because of not finding they reported not finding a same-sex provider. So this went from a sample of the first one in Michigan were men and women. Here, this is just women. Right, 53%. And those, the predictors for that, or the associations with those that had higher religiosity and obviously higher modesty levels, were more likely to report delayed healthcare seeking. So that was really striking to us, that in this population, you have a lot of preventive health things that can't occur if they're not going to go see a provider of the same gender, right? Yet, largely, no one has done any research on this. So then we did some qualitative work, and we talked to individuals how this influences your thinking about the healthcare system. So this is the first quotes from a woman who was examined by her physician in the ED, and they have to do a vaginal examination. She sort of says what she remembers from that ED visit. She actually even doesn't remember why she was there. Well, she remembers why she was there, but she doesn't remember what happened, except for she remembers that exam, and she said, "I wish the ground would have swallowed me up." That's how she feels about the ED and that examination. There's another patient who, very forthright, this is an African-American patient, I remember her, and she talks about the fact that she would wear a head covering and she'd go to a clinic, right, and and people would not want to assume who she is or what she is or whatever. And then so she's saying, it's not as if I'm the patient. I have to say, pay attention. I'm a Muslim woman. I have this modesty issue. Right? Why do I have to sit here every time I go and say, look, you can't just uncover me. I have to explain to them all the time, every time. Why can't they just know this at some point? And then there was a Turkish individual who had spent, I think, 2 or 3 months in a rehab facility after having a stroke. And his remembering of that experience was that every day I have this ritual that sort of scarred me. The worst thing for me was being washed by a woman every morning. Like I had no family to help me, and that was my daily dose of vulnerability. So that's the kind of the empirical data. Let's talk a little bit about the Islamic bioethics piece, which I dabble in, about where this is rooted and how it comes from. So we wrote this paper that has a lot of things in it. I just put it up there because there's a lot of different things I talk about, and today I'm only going to talk about a few of these issues. But this idea of gender concordance is actually rooted within the tradition. So it's not just and some people would say this, oh, it's just, as they get acculturated, Muslims have this value system, so it's just a cultural thing in patriarchal societies. But rather, it is part of a parcel of the religious teaching. So the Quran, the spiritual sources of Islam, one of them is the Quran, believed to be the Word of God. It tells both men and women to lower their gaze and guard their modesty. And there's a commandment, do not go, la taqrabu zina, do not go near adultery. So the Prophet Muhammad, the other source of sort of scriptural source is his sayings, his teachings, and his tacit approvals. He made many statements. Some of these here I share that speak to this idea of modest cross-gender interaction. He says that every religion has an innate character. The character of Islam is modesty. And he commands that unrelated man and woman must not remain alone in the same space. So from these and other scriptural sources, you have legal scholars who then explicate the boundaries of cross-gender interaction in the healthcare system, and this is nearly a consensus from scholars on this issue. So they say, again, with this big caveat, if all else is equal, and we can talk about that in the Q&A, but if all else is equal, the physician's choice hierarchy is based on this notion of modesty. So a Muslim man or a Muslim woman should pick a Muslim of the same gender, and then a non-Muslim of the same gender. Right? So the gender modesty issue. Then if after that, then the Muslim, then the religion issue. If a Muslim of the opposite gender and a non-Muslim of the opposite gender. So the modesty issue pervades, in this case you see the religious issue. And the reason that Muslims would want to see Muslim physicians, or that the scholars say that you should, is because when you have a malady that can impact your worship activities, like going to the Hajj or praying or fasting, that a Muslim physician should know when your illness is sufficient cause for you to not have to do those things. So that's why they talk about the religious notion here. But you see, the first thing they talk about is the modesty issue. And why? Well, because one of the arguments made is because of this religious concept of awra, about parts of the body that must remain covered in front of different audiences. So when men are with men, or Muslim men are with men, there's a different level of covering that's required. When Muslim men are with relations, a different level, and then when Muslim men or women are in a general audience, a different level. So I'm just going to mention the last level because that's what's most pertinent to the healthcare encounter. And this is the consensus, again, of scholars, that from prophetic statements and practices, that men should, in a general space, should always be covered between the navel and the knees, and plus or minus the shoulders, and women, the entire body, save for the hands and face. Now, that's the general idea of what your dress code should be. Obviously, there are exceptions from that when you have extenuating circumstances, like in the healthcare encounter. But if you think about the normative, this is a normative, that this is how our body should be covered, right? So this is our expectations of how we interact with the world for those who are more religiously inclined. Then you can understand why this modesty issue becomes very pervasive and wanting to seek a same-sex provider, right? Because there are parts of your body that you wouldn't uncover otherwise. This other idea about seclusion, also I mentioned that prophetic statement. So here, this idea of unrelated members of the opposite sex should not be alone. And this can potentially in the healthcare system be broken, right, when you have the idea of potentiality. And as far as my understanding, when I've interacted with Jewish colleagues, similar things happen in the Orthodox Jews, where there's a potentiality idea. So if a door is slightly ajar, then it's not closed, the potential for someone to walk in without you knowing. So there will, or that there's a curtain so people can hear. So you're not totally secluded in a private space. The potential for people to walk in or open or listen in is what allows seclusion to be broken. So you can have that idea. It's not that it has to be fully enclosed and no one can see or talk or hear. Because obviously in the healthcare system, we're trying to balance privacy with modesty, right? And this last thing, so about physical contact, so we talked about uncovering and parts of the body that need to be covered. This idea, these are, and I'm not sharing with you all the scriptural sources for lack of time, but members of so there's two dominant streams, or two dominant opinions about interaction with members of the opposite sex who are not related to you. One line of reasoning and rationale and scholars would say that there is no possibility, right? So members of the opposite sex should not have any physical contact except for dire necessity, right? And they would say medical care is a dire necessity, but that's the normative, that no contact. Another group of scholars would say, well, this is a conditional idea based on different interpretation of scriptural sources, that yes, you shouldn't, but it's not, you shouldn't have it, but the reason that you shouldn't have this interaction is because there's a fear of provoking of sexual desire, or there's enjoyment of the contact. So if that's not there, those conditions aren't present, then that's a relaxed ruling. Okay. So that's the religious sort of substrate, which might play a role in the cultural and practical mores of the individuals that you might see from the Muslim community. Again, not all of them, but some of them. So then the question becomes, should we accommodate the same provider request? Right? Does that help you think in any sort of way what the patient values are? And should we do so? So I said I want to talk a little bit about the four principles. I particularly am critical of the four principles, but we'll talk about them very briefly. So let's talk about this idea. Okay, well, should we accommodate the patient same-sex provider request from the sense of the four principles? So if you think about the idea of respect for autonomy, that autonomy is part of personhood, maybe the most important part of personhood, individuality. Autonomous choice is the main way by which individuals can act out that essential characteristic of being a human or a person. Then that respect for autonomous choice should say that you should accommodate that request. They can at least make, if you can, right? But you should take that, weigh that, and try to accommodate that because they're making an autonomous choice about their own body and their healthcare system and how they want to interact with the healthcare system. From a sense of social justice, you might say, well, they're marginalized, you should help them. Or you could say, well, can we do that for everybody? Are we going to have segregated healthcare systems for different types of people? That doesn't seem quite right. So potentially we shouldn't be thinking about accommodating this as a general practice. In terms of respect for person, right, or respecting her values, another idea that's embedded within this autonomy at times, or some say is a super category, and autonomy is the specific category. Again, same issue here. And as far as non-maleficence, I just showed you some data that would give you pause to think that there is some psychological harm that can happen to individuals, right, that does impact the healthcare seeking in this population afterwards. So in terms of that mode, we have to at least consider that we should be trying to accommodate this request when we can, right? So it's supposed to be a positive there. But we should try. But again, this is the issue, right? That do we have all these other factors do we have resources and what's the patient acuity? So let me give you a sense. So I've been studying these things for a long time. Actually, I have patient and provider level data to share with you. So we did a study of physicians in the ED, and we asked them the question with different patient scenarios, right? What's the percentage of time that you've been asked as a physician to accommodate same gender, same race, and same religion by a patient? These are ED physicians. We did the study at ASEP, which is our American College of Emergency Physicians. So you see this, that the request in the ED for gender is quite common. These other things less common, but higher than we would have thought initially. Okay. So then we said, okay, well, what would you do? What's your perception from the provider level, right? So would you always accommodate, or would you never accommodate this request? And the most polarizing one was gender as well, and not predicted by gender of the physician, right? That there's some people, a third would almost always accommodate that request, no matter who's it coming from, if they're male or female. Some would almost never. So the race and the religion one was less. So you see that this is something that is quite common in the ED, yet it is polarizing within our own practice, within our own profession. Okay, so I'm going to take a turn now and talk largely about the larger ideas of healthcare accommodations that Muslim patient populations seek from a data point. So we did this study while I was here at U of M and during my RWJ years, and we had this report about meeting the healthcare needs of American Muslims. So we did 13 focus groups in Michigan, right? Again, in the South Asian, Arab, and African American communities, because we wanted to get diversity across the Muslim demographics. And we had 102 people in these focus groups. And the question at the end of this focus group was, this was almost verbatim the question, what changes, if the healthcare system had $100,000 to spend on you all, what changes would you like to see in the hospital to make you feel more comfortable? And across these focus groups, we had them do a rank sorting exercise where they had to come up with 3. They had a list of 15. Tell me the 3 that you want this hospital or that hospital to give. So that's how we analyze the data. The most common accommodations were gender concordance as far as possible. Both men and women said this. We had males and females in these focus groups. It was top 3 in 11 of the focus groups, and 12 of the 13 that was mentioned. Halal food was the second thing. And then you see this idea of neutral prayer space. So I'm going to give you a little sense of what they said about each of these things. We talked about gender, so I'm going to stop talking about that. But let's talk about halal food. So the way in which the focus group discussed and talked about this was this idea of that because it's religiously mandated to eat in certain ways, that has to be the best food source, that is healthier in some sort of way. And then they noted that, well, if it's healthier, if we believe it's healthier, the absence of this during our convalescing period in the healthcare system seems problematic, right? So it should be helping us and giving us better nutrition to get healthier quicker, but oftentimes healthcare systems don't provide it. And particularly we're in Michigan, so there was this issue of the social justice issue, and people experience this as potentially discriminatory, right? So all I get is vegetarian. Every time I ask for halal food, oh, we have vegetarian. But I mean, everybody else gets meat except for us. And they would say they have vegan, they have low-fat this, they have low-sodium that, they have this or that, renal diet. But they can't figure it out when we have 25,000 Muslims in this area to get halal food in the healthcare system. So it was seen as a potentially discriminatory practice. You'll see this come up again. So about neutral prayer space, right? So again, the idea here that prayer itself is a source of healing, that Muslims have spiritual needs, and this involves when they're in the hospital that they should be able to go and pray. And oftentimes, most of the chapels in these hospitals have religious iconography that's of a certain Christian in origin that makes it difficult for them to feel comfortable in that prayer space. Then this idea of the social repercussions, right? So this is an individual sort of saying, we were praying and we couldn't pray there, so we went and prayed in the room. And the nurses and security, everybody came in and asked if everything was okay, right? Doctors were hesitant to come back in the room. Everybody came by after I looked at in the door. We were just praying how we pray. So it becomes a big commotion. Well, what's going on here? Why are these 4 people praying? Why are they lining up? What's going on? Especially when you have the person next door to you on the other side of that room. So it wasn't comfortable to pray in the room either. Yet there was no place for them to go pray in the hospital. So those are the accommodations, right? Data-driven, that they say. Gender coordinates as far as possible, halal food, and then a neutral prayer space. Then the question for us, ethicists, I want to stop very shortly with some comments here. So, okay, this is what we know, but what are we going to accommodate these values? Like what extent and how are we going to do that? So let me give you just a few thoughts to promote our conversation that's going to happen now. When you think about what values, right, so I made this idea that the same-sex provider accommodation is something that impacts healthcare seeking behaviors of Muslim Americans, right? It's something that they leave with, if there's not accommodation, they leave with a sense of psychological harm, potentially, some of them. And in our healthcare system, we do this, actually, we accommodate this value in different ways. So, for example, in the ED, we have victims of rape, and we call in the STAIN nurses to do data collection and examination, recognizing that this might be a very troubling time to have an opposite sex provider do intimate examinations in history. So we have trained a system of nurses who get called in to do this exam. And we provide resources for that. In the labor and delivery, yes, we don't have, and this is a case here at University of Michigan. There was an issue about this many years ago, but we accommodate to the best of our ability when a woman says, I just want to have females in the room, right? Sometimes we put things outside the room, men don't go in, okay? It's a population that we get good reimbursement for. And we do that, not that we say exclusionally, but we do that, we try to. The question is now, what do we think that's a religious motivation underlying that? Do we have the same level of attention to that value? It's the same, potentially the same accommodation on the ground, but a different underlying patient value and provider perception of that value, right? And then this idea, as I mentioned to you, now if you think that the patient is saying, I want a male because they don't think women can be doctors from where they come from or whatever else it is that something that we're going to accommodate or not? Or are we going to try to right that wrong or educate them? So I'll share with you, when I was a resident at the University of Rochester, and, I had two incidences when a patient said, and I was in training, I don't want to be seen by a terrorist. One of my attendings said, Aasim, you're not going to go and take care of that patient. We're going to find some other resident. Another attending said, we went and started to reprimand that you get whoever you have. This is not Burger King. They're all competent physicians taking care of patients. They had very different responses to that. And I had my own, obviously, internal responses. But the healthcare, I was a trainee. And you see here, we do that at times as well. There's a perception of what's happening, and then we either feel it's our responsibility sometimes to educate patients, or we say we got to be totally in service of the patient. Let's not raise the issue now. They're vulnerable. Then to what extent, right? So we talk, okay, at a patient, if I have a physician to take care of the same sex next to me, we'll accommodate that, right? Maybe in the outpatient setting, we can accommodate that. Have clinics that just, female clinics or whatever, women's health clinics. Then what about wards? To what extent, right? There are countries that have gendered wards, right? And the NHS actually had a big issue about this, creating these spaces. Do we do that here? And why do we think about that? That's a bigger, right? One provider to then one clinic to now a ward. And where does it stop? And what are the different negotiations we have to make from the ethical space to do this? Similar thing here we talk about neutral prayer space. That wasn't a request. But what if these patients said we need chaplains who are Muslim? And there's one who was formerly, I think, chaplain here, sitting in the room. But what if they said that? And we need to have a system to train them, right? We need to adjudicate what that means in the tradition. Are we invested to create that professional character for them? It's not intrinsic to the Muslim tradition, just so you know. But are we going to go that far? Or are we going to just have people come and visit whatever qualifications they have? Again, what extent, if we recognize it's a need? And then the last thing is how, right? I pick on this halal food issue because it's one that I think even the Muslim community is challenged. So for example, there are different ways people view halal food, right? There are different regulations at times. Yes, there's a base. But are we going to say we're going to do the lowest common denominator approach? That what someone says is okay, and it's easily accessible, we're going to do? Are we going to go to the stringent level approach? Right? Right? How? Right? Are we going to take what can meet everybody's needs, or what is the right? And that could be something that's very expensive, or what will meet someone's needs, and it's very easy, calmly had. And then lastly, I think, which communities do we invest resources for? Right? So we have a history in the United States of racism, right? Of sexism, of a lot of things. And we are trying as an enlightened population to right those wrongs historically. But what are the wrongs of today? And are we going to wait 30 years to correct them as well? Or do we have to have advocates for that later on? Right? Or is the time now to make it for everybody? Actually have a responsive system that has its own value system, right? That meets patients where they are at. And that will be challenging for the profession, because your character will be different then. You will have a different formation, if that's what you want to do. I think that's the struggle, that we are trying to apply band-aid measures to a cultural phenomenon and problem in the society. And unless we grapple with that culture change, and I think everything else is piecemeal. So as I said, I want to leave you some provocative comments. I want to stop there with one last slide to give you some hope that we can do things in our own practice every day. So this is a very elementary model of healthcare disparities, but only here to promote what we can do as a provider at the one-on-one level. So if you think there are three things here, and this is the last slide, that can inform healthcare disparities, which we may know or may not know for different populations. One thing, step one, I think, would be for us to work on our implicit biases, right, our own stereotypes, do some internal work. Right, to think about, well, can I eliminate that amongst myself? I'm an ED doctor, and I don't like people come to, I had very scarring experiences with alcoholics who came in and kind of hit me over the head, so now I don't like them, whatever it is, right? So are you going to eliminate your own biases the next time you see an alcoholic and not think of the last one who kind of hit you on the head, right? There are other things, as you can imagine. Or, right, so there's cultural linguistic barriers, right? We have this idea that we're going to give telephones or have interpreters. Can we actually step back and recognize that we have our own culture and the values that the patient has, we have to explicate, right? So in the models of the patient-doctor relationship, Emmanuel a long time ago, the third model is deliberative, where the the physician's an advisor or a moral guide. We actually elicit their values and then have a debate and dialogue around what healthcare action meets their values. What does that mean? You have to actually go into where they're at and have them explicate for you and challenge them at times. Do we have that level of rapport with our patients? Do we do that? Right? Can we deliver patient-centered care at that level, not some other idea? And then lastly, this idea of promoting workforce diversity for many reasons, and this will be talked about in my second lecture this afternoon. But this idea of workforce diversity, we have a lot to work on as well. But I think that at least starts to have some sense of concordant relationships, some sense of social connectedness amongst the healthcare workforce and accepting everybody else. That can create a tolerant healthcare system. Accepting is a different level, but at least a tolerant healthcare system. So with that, I'll end. For questions, I know I went over my own 35 minute time, so go ahead, please. Thank you.